Hi, Anam. How are you?
How are you?
Okay, that's great.
Thanks for joining in. Okay, we have Samia now. Yes, Samia, can you introduce yourself? Okay, I don't know if she can hear us or no. Anam, is this the first time you will appear for the OSCE?
Yeah, definitely. Yeah.
Okay, great. You are from where?
I'm originally from Iraq.
Ah, okay, all right. Okay. So you passed this last time, the exam which happened, when it happened? I don't even remember. May, yeah. Okay, great. Okay, good. So was it an easy exam or a difficult one?
Which one? The written one?
Yeah, written one.
Time was challenging, really. Time was a problem because, 3 hours in obstetric, you should hurry up because it's a long case scenario, and then you should answer it, and it is between two types. A single best answer and extended match.
Yeah.
And then rest 1 hour, and then another one, gynae. Gynae is okay. Gynae, because the case scenario is not too much long, but the obstetric, yeah, so what. But it is more clinical. It's more clinical.
It is clinical.
I think like MRCBI, but MRCBI, just 100 question. Here they have a lot of questions. Maybe 300. I don't know. Maybe.
Yeah, it's different from this one MRCPI. It's more like MRCOG, but because our exam, if we recall, me and Zaib, there was a lot of oncology and very advanced oncology they were asking.
Oncology, subfertility, and remember we had infections as well because COVID was at peak and so many questions from COVID.
Yeah, infections plus this one as well. The obstetric cases were very complicated. Twin pregnancy, when not even one pregnancy is a straightforward one. A single baby IUGR, things like that. So it was really a difficult paper. We were all thinking that maybe we will not pass, but alhamdulillah, we all passed in the first go.
Exactly.
So then OSCE was a piece of cake, I feel.
No, because OSCE was okay at that time, but now since it is on-site OSCE, so I believe this is going to be now a little bit tricky because we don't know, the system much. But if we go systematically, so what I've been, the observing for the last, the couple of months for this new pattern of OSCE, so of course it needs again, the lot of practice. So for us, because it was kind of, the online, so maybe stations were less. But in this, the Lisbon, I think this is going to be a little bit challenging. So all you guys need to do is that you have to be on tips and prepare in the lines of RCOG because EBCOG do not have, their own syllabus. So yes, you have to prepare accordingly. And of course, the stations are going to be almost same with the, the different names. And today in this session, we are going to discuss about that. So inshallah, it is going to be clear to all of you.
Inshallah. By the way, EBCOG also have their, what they expect from their training. No, there's a textbook and there's all, I will share with you people. We will make a group for EBCOG. So they also have like RCOG metrics. They also have something like that, which they expect from the students, what level the student should be on. So that is there. I will share with you people. Okay.
Yes.
So we have now Ibtihal, Shazia, and who else is there? Najma, Makhdoom. So how many people? 1, 2, 3, 4, 1, 2, 3, 4, 5 people are there. So shall we wait for some more to join in or can we start the session?
No. It's better to join for a few minutes and then we will start.
Yeah, sure. Okay. Can we hear from you, Ibtihal? You are from where?
I'm from Sudan.
Oh, welcome, Ibtihal. How are you?
I'm fine, thank you.
So you will, exam is confirmed for you? Booking is done?
Booking is done, but the visa process still.
Okay, it will be done. There is still time. Don't worry about it, inshallah.
Doctor, many people, unfortunately, they withdraw from exam because of visa problem. Yeah. I have two colleagues. They withdraw. One, she's, I think, from India, but she's living in Gulf country, and another one from Pakistan.
Oh, really?
Yeah, they say because of visa problem. I don't know really.
Is it difficult to get visa?
Yes, because the Portugal has some the different rules, and they don't allow certain countries as well, even on the visit visa as well. I have heard it from the few people before.
Right.
So yeah, I can understand. But let's see, and do they give any kind of reason that why they are not issuing visa?
Doctor, for me, I don't know because I have a dual passport. That's why I don't care about visa.
Okay.
For Iraq also problem, I think.
Okay. That's good then. That's good then.
Yeah. Otherwise, before I applied for MRCPI, but they didn't give me a seat. That's why by chance I found EBCOG. Just I want to enter exam. Yeah.
Okay. That's great.
So, Anam, have you done this MRCOG?
Doctor, MRCOG part 1, I did long time. I passed the time, but because of unrest in our society in the Middle East, that I didn't enter part 2. And then when I came to Canada, arrived to Canada since a few years, then I start searching for another exam. Because first we try in Canada, but Canada is hopeless. They don't want overseas. Yeah, they don't accept it, and unless it is GB, but you should paper you originally should be GB doctor. If you are a specialty, you will not get chance because many of my colleagues, they did the exam and they passed. It was so difficult, really. They didn't get any place. Now they immigrate to Europe. They start to go. Usually they go to UK and Ireland.
Okay. All right. Okay. Inshallah, khair for you.
Inshallah.
Okay. Dr.
Shall we start?
Yes, Dr. Assalamu alaikum.
Walaikum assalam.
Walaikum assalam. Yes, Shazia, you are from where?
I am from Pakistan. Actually, I am preparing for MRCPI, but I just wanted to take this session. Yeah.
Okay. That's great.
All right. No problem. Good. Okay. Makhdoom, can we hear from you?
Hello. Yes, doctor. Assalamu alaikum. I am Pakistani, but I live in Sweden.
Okay. So your own name is what?
Humaira.
My name is Humaira Makhdoom. I don't know.
Humaira Makhdoom. Okay. All right. Okay,
I have
Humaira.
tried to write Humaira Makhdoom, but I don't know, on mobile it is not working. But on laptop Zoom it says Humaira Makhdoom.
No problem. We are fine with both. No issue.
No issue. Thank you. Okay.
Najma, we cannot see your mic. I don't know what is the problem. Najma, can you say something about yourself? I think there is no mic even. I don't know why.
I think she hasn't joined with the audio. That's why. Okay.
She can press join with the audio.
Yes.
Yeah. Najma, you can hear us, and then please try to join with the computer audio or the phone audio so that we can hear from you. Okay, we have a new person, Asil
Al-Zunaid and Ibtihal Hamad.
Ibtihal, already we spoke with her. Asil, can you open your mic? Okay, who is interested?
Hello?
Yes, hello, Asil. Is this you?
Yeah, no, this is by my daughter name. Sorry, Annie.
No problem. May we know your name, please?
Yeah, Najwa.
Najwa. How are you, Najwa? Welcome to the session.
Yeah, welcome to. Thank you. Fine, alhamdulillah. How are you?
Good, alhamdulillah.
Alhamdulillah.
Okay, so I think we can start.
Yes. So let's start. Okay. So thank you so much, guys, for your brief introduction. So we are going to start and we are going to talk about the overview of the EBCOG part 2. Okay, the European Board of and College of Obstetrics and Gynecology, and part 2 is going to be the OSCE, that is going to be the clinical exam. So today we are going to talk about that how to go for this, the exam, how to prepare about it, and how to master on your, the skills, that how you are going to go for any OSCE exam, and which of course is going to be the on-site after a couple of years. So today we are going to be with you. You guys know me and Dr. Uzma as well. So Dr. Uzma Aleem is going to be with you. Dr. Zaib Qureshi is going to be with you. And we are going to do some of the stations in the end of the after brief introduction of this exam as well. Okay, so we will try to update you. We will try to give the knowledge with the best of our the knowledge and capacity and capability, of course. But nonetheless, this exam is fairly new, and not the so many candidates or so many the people around are well versed with this. But still, we will try to guide with the best of our knowledge. Okay, so let's get started. So know your mentors. So we are going to be with you in this EBCOG journey. So I'm Dr. Zaib Qureshi, and I'm FCPS from Pakistan, EBCOG of course, and MRCOG from UK, MRCGI from Ireland as well. This is my dearest Dr. Uzma Aleem. She's also from Pakistan, and GPS and European Board, and MRCOG from UK and MRCPI. So we both are going to be with you, and apart from that, we are already there. On the social media, we are very easily approachable. Okay, not only for the European Board, you guys can contact us for MRCOG, you guys can contact us for any MRCPI help as well. Okay, so this is for you, that now you guys have the one in the people with multiple the boards, so of course they can guide you through. All right, so in this particular European Board journey, we are going to be with you, me and Dr. Uzma both. So in terms of the EBCOG and the European Fellow of the Obstetrics and Gynecology, usually they take the this name, EFOG and EBCOG. So the first examination was held in 2016. So this is not like the old board or the old exam. All right. So what I have noticed and what I have heard from my seniors as well, that they keep on experimenting so many things. Okay. Like the earlier that it was kind of the circuit exam, 2 to 3 years. Then after COVID, so it came the online. They have completely changed the exam, the pattern. So we are going to talk about that as well. Then again, after this COVID era, they have again changed the the almost the complete pattern according to the the new syllabus, or you can say that their own the board. Then organization according to the rules and the regulations are according to the SESMA, and they collaborate with your zone. And successful candidates will become the European Fellow of Obstetrics and Gynecology, and this is how they write their degree. Okay, EFOG and EBCOG. So this is how it goes about. So we all know that the structure of EBCOG examination is going to be the part 1, that is going to be the written exam. And like we have been just talking to our dear Anam, that the written exam was kind of difficult. So yes, it is kind of very basic, very difficult, and very clinical as well. There are going to be the certain the questions which are going to be directly on the clinical situations. Then part 2 is OSCE, for which we are going to talk about much. And after passing both exams, you will be awarded with the EBCOG fellowship. So this is going to be EFOG / or EBCOG - EBCOG. The purpose of this exam is to assess the level of competency of the candidates regarding their knowledge and judgment, although skills and attitudes are also evaluated. So nonetheless, the candidate, whether it is EU or it is non-EU, okay, European or non-European, so the the knowledge is going to be the same. So they want to judge the skills and the attitudes, that how you are going to be if you are going to work in any of the European country. So of course, they have their, the set criteria, set standard as well. So this approach supports the free movement of quality assured specialists across borders within the Europe. So successful candidate will receive the award of EFOG, EBCOG, and may use this title. But this is the, the main part, what I want to focus. Passing the exam doesn't confer or imply a license to practice obstetrics. See, like I said earlier in my opening statement, that this is relatively a fairly new exam. And of course, if only we have this degree, of course we have to, the set and we have to see it from our, the local board or the local medical council where we are, that either are they acknowledging this degree or no. Okay, are they giving us any chance to write this degree on our medical, the license practice certificate or no. Like for us in Pakistan, so yes, they do acknowledge, okay, and they do give us. But again, college clearly says that having this, the degree, passing this exam doesn't confer or imply a license to practice as a whole. Okay, then again you have to check it from your local, the practice licensing, the body as well, that whether they allow you or no. But otherwise, you are going to be called as a fellow after passing both exams. So the EBCOG examination is intended to assess the knowledge gained by the candidates during their training in the general obstetrics and gynecology. And nonetheless, assessment is going to be extended to the application of this knowledge to clinical cases, and is based on the EBCOG training syllabus as well. So I'm sure you all know that the candidates who have just passed, their part one, or whenever they have passed, so they do have packed curriculum. So they do want to, the judge everything from that packed curriculum. Okay, they do have, the certain, the important modules on which they really want to focus on. Okay, so I mean, this was basically about this exam. Then this year exam is held. Usually exam is held once a year. The May month is for theory, and the November month is going to be for the OSCE. So they call it as, the autumn season, or the whatever. So this is how, they do go about it. And there, the convocation is going to be in the Poland. So whenever that is going to be, I think for the 2021 candidates, the the convocation is going to be in March, Poland. So the candidates who haven't taken their, the pass certificate from them, so of course they are going to be eligible to go to the Poland. So this year exam is going to be on 19 or 20th November, and this is going to be in the Lisbon, Portugal. Okay, so I'm sure that the candidates who have applied, who have passed their part one, and they are eligible to go to the Lisbon. So it is fairly recommended that please do apply a visa, because certain countries, they do have certain restrictions or certain the problems in getting visa as well. So it is better to be, the organized beforehand, rather than the preparing endlessly for this exam, and then sitting and then just crying that we didn't get visa. Before, of course, we need to be certain that where we stand in this thing as well, because of the complexity of the the situation around the globe. So yes, this is very much important, that at least from the whichever country you belong to, so it's better to have a fair knowledge that whether you will have any difficulty in getting visa or no. So of course, if it is visa, then of course you have to go there, and the things are going to be the challenging in terms of a financial perspective as well. So please keep everything in your mind. Okay, keep everything in your mind, and then they go for this the exam. All right, so what is OSCE? So OSCE is the performance based testing of candidate based on their theoretical knowledge as well as clinical skills. The structure is going to be based on successive sessions where the examiner will evaluate the performance of the candidates and mark them accordingly. So the examination is usually objective, because all candidates are assessed in all stations on the same topic and are marked by the same examiner using the same marking system. See, the standard of the exam or the marking system of the exam is fairly, the constant, or you can say it is fairly straightforward. Because I mean, none of the candidate is going to be the changed scenario, because every candidate is going to be judged on the same topic and will be marked by the same examiner using the same marking system, because they do have their own marking system as well. And the structure is same as the all board OSCEs. Like there is going to be discussion with examiners, and there is going to be the role play task as well. Okay, so first we need to understand that how this the exam will go. Okay, so I mean, of course you are going to have the discussion with the examiner as well, and we are going to talk that what type of discussion they are going to be expecting from us. Role play tasks are going to be there as well, and in the role player, of course, we are going to be having the professional actor or actresses. So like every OSCE, this is going to be the same OSCE in one circuit. Okay, you guys have to perform at least the roughly they will have 10 stations. And out of 10 stations, 1 station is going to be the rest station and 9 active stations are going to be there. Okay. So you have to move from one station to the other station, one after one. Okay. And one is going to be the rest station, and that is not going to be perfectly rest station, but rather that is going to be a station where you have to evaluate whatever you have to discuss with your examiner. And usually they give their critical appraisals at that station. That okay, you will sit for a while, you will take a deep breath, and then you are going to critically appraise any article, critically appraise any leaflet or anything. Then, of course, the role play tasks are going to be there as well. And the role player can be anything. Okay. Role player where you have to do the management as a shared care management plan, where you have to give, the information, where you have to do the communication. Okay. And now let's talk about what is the basic theme of OSCE according to the college. So basic theme of the OSCE is basically 5, the major skills. And on these 5 things, they are going to make their 9 or 10 stations. This is going to be the basic technical skill. Then there is going to be complex technical skills. Then there is going to be communication. Communication basically is going to be, in the gynae and in the OBS as well. Then there is going to be appraisal. Then there is going to be shared decision. So basic theme is going to be based on at least 5 things. So who is going to tell me what do you understand from basic technical skill? Anyone?
Doctor, for gynae, can I answer? Like for gynae, for example, technical skill like a laparoscope, something related to the laparoscope or to the hysteroscope. And in case of the obstetric, it may be like a breech delivery, or it's according to the type, whether it's complex or it's basic. Breech delivery, shoulder dystocia, something like that.
Okay, like name says, basic. So basic means what a candidate can perform. Okay, what every OBG candidate should know. So of course, perfectly you have said about the laparoscopy and hysteroscopy. Okay, so that is going to be the basic technical skills. And in terms of obstetrics, so what you can do individually, that is going to be your basic technical skill. For example, how to conduct a spontaneous vaginal delivery on the mannequin, how to conduct breech delivery, okay, in which you alone have to perform. It is not like the the teamwork. Then it is going to be changed. Okay, so basic technical skills, for example, you have to they talk about the ultrasound. Okay, how to do the transabdominal ultrasound, how to do the transvaginal ultrasound, the basic stuff, because college really wants us to know the basic stuff first. And then of course there is going to be the complex technical skills. Complex technical skills where you have to involve your team. And the European board really, they believe on this complex technical skills, that every candidate should pass this complex technical skill, the station. Because they really believe that, that if you are there as a team lead or as a team in charge, so how you are going to use your, the fellow colleagues. Because, and the complex technical skills, for example, if we talk about that, how we are going to talk about in the obstetrics. Okay, so there is going to be like, for example, there is shoulder dystocia, PPH, APH. Okay, then if there is, the any unexplained vaginal bleeding. For example, if there is any, the management where you have to do, where you have to involve, the other specialities as well. Okay, for example, this is post-op injury. For example, there is, the management of miscarriage. For example, there is, the ectopic. You have to, the refer any woman who has been diagnosed with molar pregnancy. All right. So the complex technical skills are sessions. Are this, the EBCOG really want all of you to be master on all these complex technical skills, because they really want to see that whether a candidate is, the able to they deal with the emergency situation. All right. So then comes the communication. Communication is going to be the breaking bad news, and communication is going to be that, the handover as well, that how you take the history, how you present it to the examiner, and how you are going to hand over the case. Okay. Then shared decision and the management. This will have, and this will also have, the role players. Appraisal, critical appraisal. So Dr. Uzma is going to talk about in brief detail in a while that, the how we are going to do the critical appraisal, how we are going to read any, the article, or, do the risk management, how we are going to, do any kind of, the, what you can say, the goods or bads or improvement or something. Okay, so critical appraisal are going to be there. So basic theme is going to be based on five the things. Okay, basic technical skills, complex technical skills, communication skills, appraisal, and the shared decision and management plan. If we talk about shared decision, then yes, your applied clinical knowledge will come into action, because in here you are going to be judged on everything, that how you talk to the patient and how you bring any shared decision for this particular scenario. Okay, so this is the same that the what the examples we have they just discussed. So what are the important stations to master on? Communication skills. So basic history taking, summarizing it, and handover. So in our exam this was there because it was an online exam, so it was there. Then breaking bad news. It can be miscarriage, cancer, ectopic, IUFD, HIV, or any sexually shared infection. Basic technical skills that you know how to conduct spontaneous vaginal delivery, forced vaginal delivery, vacuum, okay, vacuum kiwi, breeds, laparoscopy, hysteroscopy. Okay, of course, they're not going to ask you to do the hysteroscopy or laparoscopy in exam, but yes, the ABCD, the basic concept, the basic step. How much is the carbon dioxide pressure? What medium you will use in hysteroscopy? What can you do with hysteroscopy? What are the safety checks? What are the safety checks in laparoscopy? How you can define that, what type of injury can happen at primary report, what type of injury can happen at secondary report as well. Scans, this is very much important. You have to know that, what are the probes, how to do, the transabdominal scan, transvaginal scan, how many views are there. Okay, so this should be in your hand, and some of the time, they can also bring, the scans as well to read. Okay, the complex technical skills, or basically it is going to be the teamwork, shoulder dystocia, PPH, APH, maternal collapse, resuscitation, and yes, you can add neonatal resuscitation as well. Okay, so anything can come. Appraisal, critical appraisal of audit, incident report, risk management, study. Okay, usually they give, the randomized, what you call it, randomized control trial. Okay, so they do give, the certain, the systemic analysis as well, randomized control trial as well, case control study, cohort study. Any type of study they can give you and ask you to, they elaborate that, how you are going to critically appraise. And that, of course, is the, the separate station to discuss. Then shared decision and management. In this, you are going to have role player, and plus you are going to have examiner. And I have heard that, the earlier, before COVID era, so they used to have, the one lay examiner as well, like RCOG. Okay, because they do have, the certain RCOG examiners as well in real exam. Okay, so clear this part, guys, that what is the basic theme and what are the important stations to master on. Clear, everyone? Okay, very good, Anam, very good.
Dr. Zaib, excuse me.
Mm-hmm.
Yeah, I have doubt about this communication skills and shared decision and management. Same, this is as a role player, history taking, examination, communication, same?
No. In this, the handover, this is basically, the handover in which you are going to have a patient and you are going to have an examiner. Okay, it will be written that, okay, do talk to this lady. Okay, do talk to this patient, take your history. Okay, then, whatever you want to take the information, and then you are going to summarize it and you are going to give, this handover to your examiner, who is going to behave as a, your fellow colleague. Okay, like we do in our daily day-to-day basis. For example, you are going to, they close your shift, and the another doctor is coming in. Okay.
This is SPAR, doctora, like
No. Don't bring too many things into one session. Just remember, it is handover. Okay, we're not talking about SBAR. We're not talking about SBAR. SBAR is totally different. Okay,
Okay.
SBAR is going to be in the when you have to prioritize. Okay, sweetheart. So this is not going to be, the basic, the like this. All right.
That's like long case, and history will take history, then present this all to the examiner, then he will discuss with me the.
No. He's not going to discuss anything with you. Okay. You will just take history from patient. Okay. You will just take history from patient, and whatever you have extracted, you will summarize it and you will, tell it to your, the consultant. That's it. Or you can propose your, the basic management plan as well. Am I right, Uzma?
Yeah, yes, okay, clear. Thank you.
Yes, Zaib, actually, you see, partly you are correct about this S-bar. I think Najba, yeah. So they what they are testing in this station is how you communicate with the patient in terms of history taking, if your history taking is proper or no. Okay, because in our exam they told us that you will just take history from the patient and then you will communicate this to your examiner. So once we finish history taking, you will, of course, it's better always to follow the S-bar pattern, where you will tell that, okay, this is whatever patient so and so age that came with this complaint, and you will summarize the case in S-bar pattern, and they will say, okay, what is your plan, and then finish.
Well, here, because the thing is, when I proposed my management plan, so the examiner told me, she said it at that time that no, I don't want management. Okay, now it's done.
Oh yeah, they don't expect management from you. Their basic aim is to test your history taking skills and how you will hand over the patient to the next person.
Exactly, that's it.
Okay, but once you are handing over the patient, better to follow the S-bar pattern of things. That what is the patient, what is her background, and what is already done.
Exactly.
Maybe you can just delete the plan because she also stopped us that I don't want plan from you. So this is what they are testing here.
Exactly.
Okay, clear. Thank you. Very clear.
Okay. Because for me, I usually keep things simple. Okay, in all exams, in all boards, I don't go into so much of technicalities. Okay, so what I believe is that if you will go step by step, if you will go in systematic way, trust me, you will not even need to remember this S-bar at that time, because in that the adrenaline rush, you may forget what exactly was B, what exactly was A. You got me? So if you will go systematically, you will just take, the basic history taking, you will just summarize it to the examiner and you will just do the handover. So this is just basic handover. Okay. Okay, great.
Depends on the topics that's given or the station, and if this it's depend on the topic, the station.
Exactly.
Breaking news, handover, etc.
I'm coming to type of discussion. Okay, don't worry.
Okay.
So these are the basic the basic technical skill and the complex technical skills. Okay, so please do master on Kiwi, because Kiwi these days they are working on Kiwi almost all around the globe. Okay, so you should remember at how what is the actual pressure, when you have to release, where you have to do, because of course it is going to be an on-site exam, they are going to have many queen as well. Okay, so please do master on. If you are not working in hospital, do go to the hospital. Okay, do try to familiarize yourself with all these types of instruments, all these types of the forceps and blah blah blah. Do examination. Okay, the basic technical skills is going to be per abdominal examination, per vaginal examination, per speculum examination, myelina insertion, how you are going to take HPS, okay, how you are going to, the insert IUCD. So many things are going to be there. Yeah. So in terms of, the complex technical skills, so yeah, hysteroscopy, laparoscopy, shoulder dystocia drill. So many things are going to be there. So you can bring, whatever you want to bring in. But always remember, common things are common. Common things needs to be mastered on first, and then you will move to the rest of the station. Okay, if somebody knows each and everything about laparoscopy, but she doesn't know anything about shoulder dystocia, so according to me, this candidate doesn't deserve to pass, because shoulder dystocia is fairly common in our the every OBG. There is not everybody is doing laparoscopy. Like if I can tell about myself, I do want to do minimal access surgery, but I cannot do it. I don't want to do it. I don't have any interest. Okay, so not everyone is going to be advanced in almost all advanced technical skills, but always remember, this should be on your tips, this should be on your tips, this should be on your tips. Shoulder dystocia, PPH, APH, uterine inversion, almost all obstetrical emergencies. Okay, so all obstetrical emergencies for which we do have protocols, we do follow protocols, those should be on your tips. And then of course, we have to go for complex technical skills as well. Okay, so let me tell you the theme of exam. So there is going to be, almost 10 stations like a circuit, okay, and 9 stations are going to be the active station, okay, 10 minutes each. 2 minutes is going to be the reading time and 8 minutes to perform roughly, okay. So it's not like that they are going to ring the bell all the time and then you have to do, okay. So if 10 minutes are over, then of course you are going to move to the, then you are going to move. Total 180 minutes for to perform. So the task number 1 is going to be, for example, rest to evaluate the article. The second, in here you are going to see the examiner and you are going to discuss the article, whether it is the whatever type of article it is, or either it is risk management, either it is the discussion on the incident report, discussion on anything. Then there is going to be the basic technical skill obstetrics, basic technical skills gynae, okay, complex technical skills obstetrics, complex technical skills gynae. Then 2 communication skills may be there, okay, like I have told you earlier, that one can be the handover and one can be the BPM. Then shared management in obstetrics, and 10th station is going to be the shared management in obstetrics.
Can you repeat for the communication on the skill station, what will be 7 and 8?
Sorry, communication?
This 7 and 8, what will be the scenarios?
Means, you have to take the history, you have to summarize to the examiner, and you have to do the handover. This is going to be the one scenario. The other is going to be the breaking bad news. Most of the time, because they really want to, the judge that how you break the news, how you communicate, how you go about, this type of, the sensitive, or you can say the important scenarios. Okay, Reena?
Yes, thank you.
Okay, great. Clear, everyone, regarding, the task, how many stations and how it is going to be? All right. So, each station will be scored from 0 to 20 points, and total marks are going to be 180. And final score will be converted into the percentage, and then result will be compiled through designated criteria. They do have their own criteria. If I'm not wrong, that is termed as, I think, the modified modified Rutherman criteria. Okay, so they do follow that criteria, and pass marks will be the median score evaluated by the examiner as borderline. So it is said that ideally 7 out of 9 stations should be clear pass. But as a candidate, our aim should be 9 on 9, isn't it? It means that we have to be prepared for almost all stations, but to pass this exam, at least 7 out of 9 stations should be clear pass. It means that you are, up to the mark in all those stations, and complex technical skill is going to be almost the basic one. That they really focus on teamwork. They really focus on how you are going to behave if you are in hospital, anywhere in the Europe. So the result usually will be published in 20 days, and they do send emails, and you will be notified on that. And the weightage of the marks will be done by the committee beforehand, and every station will be judged according to the particular domain. Like I said earlier, that in complex technical skills, shared, your teamwork. If it is communication skills, then of course, for example, if it is BBN, so communication skills. For example, if it is handover, so communication with colleague. Okay, so of course, patient safety is going to be the prime, the thing in every board there is, isn't it? So we do go for patient safety as well. We do have to take care of this point as well, that how we are going to behave in almost all stations. Then, of course, if you pass, the both exams, so you are going to be awarded EBCOG degree. So I think this is, the fairly straightforward. So usually, the what we were, discussing earlier, that this exam focuses, the mainly on clinical aspect. Okay. So your clinical things are going to be, should be up to the mark. Okay. And, the critical appraisal part, because as because many of us are aiming for MRCOG or Irish exam as well. So of course we are not that well versed with the critical appraisal, because now MRCOG has taken down that, the critical appraisal, the thing. But for this exam you have to do that, okay? And it will come with the practice. So please practice, practice, practice. So with the only the practice you can master on all these things. All right. So communication needs practice. The how you are going to deal with any that technical skills, that is going to be your the exam as well. In terms of the teamwork, for example, the you have been given a task and you are talking to your the examiner, and suddenly the someone will pop in, and someone will tell that, okay, we have an emergency, and that is a quad prolapse, so come and they do there. So examiner will ask you, so okay, you have got a quad prolapse now, so tell me how you are going to manage this quad prolapse. This is how it goes about. It's not like that you will be taken to the hospital and wards, and then you are going to be the dealing with that. Okay. So the examiner will change his mind or change his topic there and then, and he will ask you that, okay, now you have seen that the emergency has arrived and it is quad prolapse, or for example it is PPH, or the placenta previa, in terms of the APH. So how you will go about it? So of course then your protocol will come into action, and then you are going to do accordingly. Okay. So we all know that we have got designated protocol. Okay. From the RCOG curriculum, we do have APH, PPH, we do have the maternal collapse. Okay. All those algorithms. So all these algorithms again should be on your tips. Okay. So you should be knowing that what you are going to do. For example, if it is placenta previa, how you are going to go about it, how you are going to manage. So this should be on your tips as well. Okay. Clear everyone regarding stations? Any question? Hmm?
Yes, clear.
Okay, okay, very good, Nachwa, very good. So, the how to prepare final exams. Just let me share a few tips and tricks, and then I will hand over to Dr. Uzma to do the the station with you guys. So, how to prepare for the final exam? This is very much important. Okay. So, as a med exam expert team, we are offering, the mocks, we are offering, the course as well. So any one of you, if it is interested, so you guys can book, the mocks as well with me and Dr. Uzma. Okay. So these can be the choice of 6 or 12 stations. Okay. And of course, we can guide you thoroughly. And in terms of, the, apart from this EBCOG, so yes, we are available for, the MRCPI and, the MRCOG OSCE as well. So apart from that, top 5 tips to prepare for OSCE, general rules. Okay, so what are the general rules to pass the OSCE? Not this OSCE, but every OSCE there is. First thing first, know your syllabus thoroughly. Okay, you have to have your a good grip on your syllabus. You have to revise your syllabus effectively. Don't take any exam and the very lightly. Okay, always remember, because every exam we do invest a lot of ourselves into it. Okay, we do invest our time, we do invest our energy, we do invest our money. Okay, because everything we have to think about each and everything. And on top of we shouldn't take any exam as that, okay, this exam is like, I mean, very easy, this exam is like, I mean, okay, I can go with the preparation. Remember, for every exam you have to work hard. Trust me, when I went for my MRCPI OSCE to Dublin, I literally found a lot of difference in the MRCOG and MRCPI OSCE. Okay, MRCPI again, it was very much clinical, but I had to spend a lot of, although I was so well versed with so many things because I'm teaching as well, but still I had to work hard for MRCPI OSCE. People used to say, no, 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 you can pass, but still after giving exam I had this thing back in my mind that it can be anything, because you can expect anything, because I saw so many failed candidates over there as well. It was their second attempt, some of the people had third attempt as well. Okay, so this is going to be my sincere and humble suggestion to all of you. Please don't take any exam so lightly. Okay, just give your 100%, give your best to the every exam there is. Don't take that this EBCOG is going to be the very easy because you have passed the all exams before. So yes, That knowledge will come into action, but this exam has different focus, different preparation. Okay, so we have to see every exam according to their own, the perspective and angle. You have to aim for focused and time bound preparation. History taking, you know that how to do the history taking. Okay, you can rehearse it with the real partner, real patient as well. You can rehearse it with your study partner as well. Okay, so there are multiple groups, the here and there. You can be active, you can involve, any of the mentor. So I'm sure nobody is going to say no. There are plenty of mentors, who are working, so you guys can take focus mentoring as well. Okay, like, if you are in hospital, because you have to know about, the old drills, pph drill, shoulder dystocia drill, the any how to do the the emergency. For example, if there is an emergency, gynecological emergency, ovarian torsion, ovarian cyst accident in pregnancy, fibroid, the management in pregnancy. So of course, you should be knowing that. Instruments handling, for example, you should know that, okay, these are the forceps, but what type of forceps? Okay, these are the, the kiwi, or this is the vacuum. Okay, so how we are going to use it? The like, the laparoscope, stereoscope. So basic stuff should be there. And most importantly, what is the most important top 5 tips is going to be rehearse and rehearse. Okay, so rehearsal is very much important. Practice and practice. Don't just think that you will just sit and, you can just the pass any exam. All right, you have to invest a lot of energy into it, a lot of, the practice. So everything will come with the practice. Like I said earlier, that in this particular exam, the critical appraisal, they are not so much well versed of that, because, the because of, the one or so many other things. So it will come with practice, that how to critically appraise, the any study, how you are going to, go about that. So everything has a different perspective. All right. Then what are the top tips for scoring high marks in each station? All right. So read and follow the instructions. This is very much important. And if you have been given a notebook, use that notebook, and don't just write down complete on, the question onto that. Just write down important stuff, that what exactly you are going to talk about. Verbalize your examination. Okay, so you have to speak. If you are, the examining, if you are performing any task, okay, so you know how to do. Okay, I will do this, I will do. For example, this is shoulder dystocia, and the situation is given to you that, okay, that you have been called in the the labor ward, that a patient has developed shoulder dystocia. So how you will go? So you need to know that how you are going to, you are going to verbalize. Okay, so this is again going to be the complex technical skills. But yes, on the other hand, I think this is almost, the every other day we do come across with shoulder dystocia. Be in the moment. Be in the moment mean, the station you are in, just think about that. Provide specific information. Don't just think of, the giving a lot of information, because you are full of information, but examiner or the role player really just want to take the, the information whichever is important to her. Be aware of your verbal and non-verbal communication. This is very much important. Verbal communication, what you are uttering. Okay, the choice of sentences, the choice of words, what you are talking. Because fairly, we all know that, of course, in Europe there are so many different languages as well. Okay, the French, Spanish, Polish, or so many other languages. But of course, this exam is going to be in English. You may come across with, the different accents, because I still remember, that we had one examiner, and I had very hard time understanding in his, the English as well. So I will advise from my side, and I'm sure Dr. Uzma will agree with me as well, that you should understand the different accents as well. Okay, do open YouTube, do try to, the watch different videos, okay, from the different accents. When I was preparing for this exam, so I literally took help from PLAB videos. Even till date, I do take help from PLAB videos. I do take help from UK, USMLE videos as well. Okay, basis. Then there are multiple MRCGP, the any GP exams as well, because you have to understand, the different, the accents, that how you will, the understand their English as well. But remember, the exam is going to be in English. Okay, be it although it is European board, but basic exam is going to be in English. There may be difference of, the accents as well. If they are Polish, if they are, the Spanish, if they are, they're speaking French. So of course their English is going to be having, the little bit accent. Okay. So be extremely careful. Do not ignore the patient. Okay. Do listen to the patient at all times. Do take cues. No, okay. So sorry, I forgot this. So non-verbal communication is going to be that how you are showing your emotions from your body posture, from
Body
your
language.
face, body language. Okay. Your shoulders. Okay. How you are reacting, how you are behaving. For example, she has given you a history that, okay, I'm in same-sex relationship, and you're like, no. Okay. If she is giving you any if she is HIV positive, and she tells you that I'm with the multiple sex partners, so you're so okay, so what? All right. So keep your expressions blank. Okay. Your non-verbal communication will be counted a lot. In terms of this, the non-verbal cues, if you are ignoring the patient, so you might miss the some cues if patient wants to give you. Plus, do not focus on examiner, just focus on patient. Okay. Focus on patient, and then if examiner is there, don't just look at him or her after everything there is. All right. And foremost, do not talk too much. Just give precise information. Just give the information which is needed for that particular station. Because you may be the more knowledgeable than anyone there is, but this or maybe the station doesn't need that much knowledge. Okay. So just be in the moment, and just demonstrate your clinical skills. You are not going to get any credit for simply saying that you would do something. Okay. You have to involve, and you will receive the credit for the task completely if it is you have completed your task. And of course then you are going to get the the full marks. All right. So you have to treat the the simulated patient as you would treat your real patient as well. Okay. So you have to be in the moment, you have to verbalize your examination, you have to use the specific information. Don't bombard the patient with the a lot of information. Okay. Be aware of your verbal and non-verbal cues as well. Don't ignore the information. These are all the top tips. I think these are going to help in almost every exam there is, isn't it? Clear, everyone? Clear, everyone? Any question? Very good. Very good. Okay, that's great. That's great. Okay, so Dr. Uzma, would you like to add anything into it?
No, I think that was a very detailed introduction about the exam and how to go about it. It's very much clear. I think everybody should agree. Not should agree, they will agree most likely. There is no should here. Okay.
Yes.
So,
Okay.
anybody has any
So,
questions, they can ask. Otherwise, we'll start with the station. Anybody want to ask anything? Okay, so
Dr. Uzma, hand over to you.
Yeah, all right. Anybody who want to take the station, please? I want one volunteer. Come on, it's just a session.
Yes.
Do not worry. Come on.
And it is a very good the station, I must say. And guys, you won't believe that when we were practicing, so I'm very weak in all these stations. So I was after Dr. Uzma to teach me the risk management. I was after her all the time, crying as well at times, that I don't know how am I going to perform in audit and everything. I don't know anything. And she used to teach me at that time. So please take this advantage that she can teach you well risk management. All right. So come on, any volunteer? Or we will perform the station ourselves.
We will perform the station. Come on, girls.
I think.
Come on. Otherwise, I will pick someone.
I will take it, doctor. I will take it. I try.
Yeah, try it. You will enjoy. Okay, don't worry. It's a very good station.
Okay. So before we start with this risk management thing, as Dr. Zaib already explained to you people that there will be like two stations confirm will come out of these. One will be a risk management. The risk management can be any obstetric thing that happened, anything that happened in the emergency, any mistake which was made. It can be a missed ectopic. It can be something you don't know how to deliver a baby with shoulder dystocia, or some IUFD happened, patient came with the decreased fetal movement, and you didn't do what you were supposed to do and the baby died. Then there is an investigation, and then you have to, you are doing with your clinical director, and then you have to explain why it happened, what you can do to, avoid this thing happening from any next time, and how the investigation will happen. You will put it in your e-portfolio. So it can be any situation. What we will do, it is a very common one. It came in our exam also. It is coming repeatedly in the RCOG as well. And it is a very important in terms of our daily practice as well. Then coming to the critical appraisal. Now, critical appraisal can be of any article. They will bring a small article where you have to evaluate. You will start with when the article was published, which journal it was published, what is the main topic of the article, what type of study was used, what are the strengths of this article, what are the weaknesses of that article. And once you finish with that, they will ask you that would you like to incorporate what they suggested in the article into your daily practice? Then you will comment on that. Okay, then it can be an article, it can be an audit. They will show in front of you and they will say you critically appraise the audit. So you will go about it. You should know how the audit is done. You will try to find out what is done good, what is done bad, and how you can improve on it. It can be a patient information leaflet. So these two things will come for sure. Okay, and you will have this, the 9, you have 9 active stations. One is a preparatory station for the, either it will be a risk management or it will be a critical appraisal. Okay, so you have to prepare yourself in, according to different situations you might come across as a risk management. As I told you, maybe a baby is coming with Erb's palsy and the baby had shoulder dystocia. You are the one who delivered that baby and there was a delay in delivery of the baby. The things will be provided to you, and then you will speak that what happened that time, how you can improve. You will talk about drills, more sessions, more, things like that. Am I clear?
Yes, doctor, yes.
Okay, so your station will be for 10 minutes. You have 2 minutes reading time and you have 8 minutes performance. Okay.
Okay.
Wait, I will show you the station. Anybody want to ask any question before we start our station? Okay, no one has any question. So this is your task. Okay. There are 2 pages. Once you finish this page, let me know. I will put the second one. Okay. Just let me know once you are done with this page, okay?
You can change it, change the page.
Are you ready, doctor?
Yeah, doctor, yeah.
Okay, all right. So what would be your initial step with regards to the serious incident investigation?
Yeah, so it's, I mean, yeah, structural discussion, right, doctor?
Yes.
Yeah, and I'm ready for structural discussions for today. So my immediate response, first of all, I should go through the case note, and I will check what is the sequence of the events, what happened in that time. So can I see the first paper, doctor, please? Yeah, so first of all, incident report was written already about the cause. First of all, I should, first when I see the patients first, when I see I think the patient was seen by somebody else as well. Was it in? Okay, so first I will go through the incident report, and then I will go through the case. I will through the event, what was happened exactly in that day, in which first of all I was the case was handed from the one of midwife to me to suture the episiotomy. I mean to suture the perineal tear at that time, and then at that time I was in hurry, and then I will shift it to this emergency cesarean section. So in such case, I will go through the each is apologize what was happened first in that day, and then I will go through each step what was happened exactly, and if there is a swab was retained in the vagina, I should apologize here to the patients, and also I will examine the patient's vital signs of temperatures and other vital signs, pulse rate, and then I will examine the abdomen and I will examine the vagina to see if there is any vaginal, there is an offensive vaginal discharge. So I will take a swab from the vagina and I will start antibiotic for the patient. This is from patient side. And from the conditions of incidence report, I will go through the steps, what it was happening exactly in that day. And this is never events, and it will be escalated to go to the root cause analysis to find what happened exactly in that day, why it has happened, and who was involved in that problem. Usually there is an investigations will go through this case to involve who was there, the midwife and the doctor and another colleague was present at that time, and why it's happened, because there is usually they count the swab before the procedure and after the procedure, because it was shifted from one person to another person, and in a hurry case that the major cause of that's a problem. So I think the recommendations is it will go through the investigation for this case, and the recommendations, I think it will be a need to increase the number of the staff in the labor room at that time.
Okay. What steps would you take in terms of your training progress?
Yeah, so for training progress, usually should be I mean, even if the busy situations, should be drill at that time. See, it should be drilling for that procedure. What is the step should be taken before perineal repair, and what is the step should be taken after the perineal, and who will do it, and what is the circumstance at that time. Should not in a case of hurry up, otherwise we will miss something and will make a serious problem. And also, the steps of the perineal tear should be should be step one by one. We should follow up the steps, not in hurry conditions. Otherwise, mistake will happen.
Okay. So, what additional resources or help you think can provide further support to you in this situation?
I think I should. It may be in these conditions. We met my clinical supervisor, and I will discuss the case with him in which events has been the event has been done has been done at that time, and what is the next steps IP should to upgrade my dealing of such situation, because this is never event, and it's. And also I should put it, I think, in the clinical portfolio, electronic portfolio, I should involve also, I should put this in.
Okay, what measures would you take to prevent such incidents in the future?
Yeah. So if it's single conditions, it's usually is a drilling, and if it's recurrent conditions and what's happened in over a period of times in the hospitals, we will go, I think, for audit procedure.
Anything else?
I think, yeah. I think that's all.
Okay. How would you approach the woman and family afterwards, giving her that care was less than suboptimal?
Yeah, you are right. The duty of conduct should be first, I should apologize and I acknowledge what was happened. And then I should go through the whole situations in a more transparent way. And also, as I mentioned earlier, I will examine her and swabs while taking an antibiotic will receive and follow up of the patient.
Okay. Okay, so this case study should prompt you to reflect on what for yourself?
Reflect on myself. What's the proper way of practicing in such rush conditions, rush state in the labor room, when there is rush between the theater and between the labor room? I should be more critically organized, how to deal with the cases and how to handle the cases from one person to another, and who usually will do this procedure and who will do this procedure.
So what were the loopholes you identified in this case?
So, sorry, doctor, can you repeat your question?
What were the loopholes, weaknesses, or mistakes you identified in this particular case, which you want to address?
Yeah, you are right. The weakness, first of all, it was this case was asked by midwife to repair the perineal tear by me, and then after without checking, accurate checking of the swab before and after the procedure, and also I handed the case, I think, because I was rushed to the cesarean section to another midwife. So there is a problem in such conditions. If I hand over, it should be in the ice bar way and should be in a proper way, and also without hurry up, otherwise one mistake would happen. So I should be organized in handling the case and how to hand over to my colleague.
Okay, anything else?
Yeah, and also on such a rush hour, I could call the consultants in case for emergency cesarean section, because I was busy with that case instead of hurry up and take over to the cesarean section.
Mm-hmm. Okay. Anything else?
So now, yeah, because usually when we have after incident report, if that's like never events, and there is
time finish. All right. Okay. Okay. What do you think? How you performed, my dear?
It was confusing up and down. This is an interesting case, really.
Yeah, it is very interesting. But I want your reflection on your performance. What do you think? Start with the good points, please.
Yeah, it's because maybe I should read the case.
No, start with the good points. You performed well.
Yeah.
So what were the good points in yourself?
Good points. Yeah, it's the incidence report there, root cause analysis there, drilling there. If there is repeated cases, audit there, electronic portfolio also there. How to manage the case in emergency, not to hand over in the rush way without be organized, because each patient is a human being. They're not in hurry up, because in hurry up a lot of trouble will happen. Yeah, but it maybe I should be more organized to the step. What should we follow up? And I should read the case scenario more deep, I think, because because I think I didn't examine the patient after the incident. Somebody examined the patient rather than me. Maybe I mix between this.
See, this is the importance of reading the scenario properly. You read it because it is a long scenario, and you can identify so many problems over here. So you were the person who delivered that patient, right? you were called, you did not deliver the patient, you were called by a junior midwife because she was unable to suture that episiotomy or a perineal tear, whatever was there. And you were also in a hurry, you were busy. You came, you sutured, and you rushed back to the labor room because there was an emergency cesarean section for some abnormal or suboptimal CTG going on. So you had to go there, okay?
Yeah.
Now this is a meeting with your clinical director because the patient came later with the infection, swab was found written in the vagina, incident report was already raised, and now you are in front of the clinical director, okay?
Yeah.
And now what is the more important? You should read the second slide. No documentation in the notes to suggest. So one is busy labor room. You are not taking handover from the midwife. And why she called you, why the other midwife was not there, why she was doing some phone call advice, was that more important, or this perineal repair was more important? Then without documenting anything, though there is no documentation, poor documentation, busy labor room, inadequate staff, untrained people who are working there, who cannot suture a perineal tear.
Yeah.
So many things you can identify from the case scenario, right?
Yeah, correct. Yeah.
So this was our exam case also, and it is very important. Otherwise also, you know, sometimes you will find a case where an incident is raised that the patient found this swab in her vagina, or the patient came with foul smelling discharge and you do speculum examination, there is a nice swab sitting inside. So this is a never event. You identified and you went in a very right way. So basically, you covered everything that needs to be covered in this station, and you are close to pass. I have no doubt in that, and it's a very well performed station by you. And there's always room for improvement for everything. So this is how you can improve. So my first question was, what will be your initial step with regards to the serious incident investigation? So what you should include, you should assess the risk team in the investigation process. The risk management, they will contact you, and now you will cooperate with them with any further investigation. You will prepare a statement after reviewing the notes, and you will seek advice from the clinical director. Okay, these things are very important. So please remember all these points. And you will speak to your supervisor and the college tutor for any additional support, because this is a never event. It will go into your e-portfolio. It will stay there. Okay. So whatever you are going to give in writing, it should be discussed with your seniors before it, you know, it is actually given. Then my second question was, what steps would you take in terms of your training progress? So this is, you will review, you will reflect and document it in your e-portfolio. So this part you covered almost. And the doctors, they should disclose the incident on Form R for the ARCP. Other medical professionals should discuss in the annual appraisal. Then what additional resources can help you? So these were the resources, okay? At the trust level, your supervisor, your college tutor, the director of the medical education, your program director, the confidential counseling services. You have all these quality departments in the hospitals. They have different branches. So you should, you know, you can take help from them. And your friends, your colleagues, and your medical association, they all can help you. Because if the patient goes on taking this incident further to sue the hospital or to sue you, and your license can be in danger, then you should know, be very, very careful once you are dealing with any incident like this. And how you can prevent such incidents in future? Yeah. So you should be aware of the situation where multiple teams are involved and the case you are receiving from the other team. So proper communication is most important, handover of the care. Then remember patient safety checklist, discounting the swabs during procedure, after procedure, and documentation. Then recording the check. You will, you know, there's a sheet which you can introduce in your routine if it's not there, where you will take and you will sign that, yes, I've counted and they are complete. Okay. And prioritizing, this is what I was saying. that the senior midwife who was on phone, was that more important, or dealing with this perineal tear was important while you are rushing from one place to the other, and in between you are doing this work? So prioritization of the task and appropriate delegation. Who is going to perform the task? Am I clear?
Yes, Doctor, yes.
Any question from anybody? Okay, then the approach, how you approach the women and the family. You were right, duty of candor is there. You will be honest and open, and you will then perform the evaluation of the patient and the risk, and you will tell her that, okay, this is something which should never have happened, and apologize, and you will tell that we are investigating into the matter, and we will keep you updated with each and every step of the investigation. It will be shared with you. You reassure the woman and her family, and that you will tell her that we will try our best that such things never happen in the future, and it should not happen to anybody else. If anybody has seen this, there is a video also on Strat OG of the same station. So if somebody has that video, you can go through how the patient is acting and how the doctor is dealing with the case. Okay. So how you will reflect? You will maintain your professional standards of care, that is good communication and teamwork, then good clinical care and handover of care, that is number of swabs, shops, instruments from one to other professional. Your documentation should be very appropriate, and the impact of revalidation once you are involved in a serious incident. Okay. So this patient, it was discharged. Patient was discharged on broad spectrum antibiotic to prevent sepsis. The clinical review appointment was made. Clinical lead and risk management group and duty of candor was done. Then supervisor, they logged the incident into your record. And following the investigations, what was felt? It was workload and staffing number was not, matching. Workload was more, staff was less, and there was an omission on the part of the attending midwife, and then you did not check and document the swab count. So what changes were made, that whenever a procedure is taken over, you must clearly document handover of the procedure, including swabs and instruments. And it is good practice for midwives to count and discard the swab they have used during delivery, and to use a new set of swabs for the perineal repair. And a checklist of instruments, swabs, and shafts was introduced. Okay, so the key issues identified was busy labor ward, midwife attending not confident to complete the repairs, so she called doctor. Doctor was in a hurry. Okay, so what action you need to take here? You should train all the midwives so that they're competent to suture the tear. Then staff failed to assess the workload. So the senior midwife who was present, she should have assessed that there is a less manpower present, so they should call people from home, or on-call people should have been summoned instead of doing things in a haphazard way. So medical staff should prioritize urgent tasks and delegate non-urgent tasks appropriately. Then failure to communicate how many swabs. So again, it is a training issue. So regular teaching and skill trainings for all trained midwives. Failure to undertake swab check before and after the procedure. So you should make a list. In the ward, each delivery, it should be countersigned by the doctor and the midwife attending the delivery. Okay, and the poor documentation was there, thing which was identified. So you should have mandatory subject area and operative records for instruments and swab counts. Okay, any questions, girls?
Just I want to ask one question. What is the difference between a clinical director and the educational supervisor? Who is my consultant? Or
educational supervisor.
Supervisor is the one who is next to you, okay? And then once things go above him, it comes to the director. Okay. It goes to the director.
A clinical director usually is a doctor?
Mm-hmm. Yes, doctor, of course.
Of the same specialty.
Not necessarily same specialty, but of course they are, in the same, they know about the quality and everything. Okay. So they are people from the quality, they are doctors, but your supervisor is from your specialty.
Yeah, okay. Yeah, okay, clear now.
All right. So whenever you are doing risk management, so you have to identify, assess and evaluate, plan, and that plan then you have to monitor and review. Okay. So when you start any case assessment, any investigation assessment, so first of all, you have to identify, then record the risk in the risk register. You have to assess and evaluate, then you have to go for a treatment plan, monitor, review, and if it is to be reported, you report. And if it is something very catastrophic has happened or a never incident has happened, then you have to escalate at the same time. There is something called a risk matrix where you divide it into the categories and you see at what type of impact that risk is making. The impact can be either insignificant, it can be minor, moderate, major, or catastrophic. Okay, then there is a likelihood ratio of that thing happening again. So either sometimes something which is a rare happening, something which is unlikely to happen, then there is something which is possible, likely, or certain will happen. So accordingly, you will deal with the risk and you will manage. So as you told that whenever a risk has happened, whenever any incident has happened, you will raise an incident report on the DATEX system. You will start investigation of the incident. And the investigation should be proportionate to the incident and the harm caused. Okay. So if it is a serious one, then all the senior people will be involved. So informal manages local investigation, concise investigation. It can be a comprehensive or an independent investigation. So what you will do after investigation? You will do the root cause analysis. You will monitor if the incident, and you will assess the risk, and you will do duty of candor. And many people, they don't know what is duty of candor. So duty of candor is you tell the women something has gone wrong. That is being honest. You apologize and you offer an appropriate remedy or support to put the things back in place. You explain fully the long and the short term possibilities of the incident that has happened to that person. You identify a point of contact, which could be a risk manager or a lead midwife who will deal with them. Then you will invite the patient and her family to be involved in the investigation process. You document the conversation in your health records. In an inpatient setting, the duty of candor sticker should be used. Okay. And a letter should be sent to the woman within 10 working days to summarize the duty of candor conversation, and it should be recorded in the DATEX. Okay, so I know you don't have in 10 minutes, you cannot cover all these things, but even if you verbalize most of it, just not in detail, but main things, you will still pass the station. Okay. Everybody is very quiet. Is it something very difficult or very easy?
Yeah.
Or what?
Yeah.
Everybody knows about it. I think it's easy.
It's not easy.
Seems like.
Okay.
No. It was a very good try, Anam, I must say. Okay. Very good.
It's a really good try. Okay,
Yeah.
so basic questions, what you should do, what could go wrong? That is identification of the risk. So what are the chances of it going wrong? And what will be the impact? This is what? Risk analysis and evaluation. And how can you minimize the chance of this happening or to mitigate the damage when it has gone wrong? That is treatment, okay? The risk treatment. And the cost of prevention is compared with the cost of getting it wrong. Okay, so there are things where you don't want them to happen in future, although their impact is very low on the public, but the cost of doing it is very high. So that is not a suitable thing to do. But if the effect of some incident happening, it is catastrophic or very serious, then how to manage in advance with that incident is very, very important. So that is called a risk treatment. And what can we learn from things that have gone wrong? That is called risk control. You share and you learn. Okay. So this is from our great RCOG. the consent, this is about the incident report, what you do. We have already, talked about it. This is very important slide, and if you just read them, you can manage any risk management station. Okay.
I have a question.
Yeah.
Incident report. I mean, I should write incident report, or the midwife will write incident report in such condition, or who will write?
Anyone can write.
Anybody can write the incident
Anyone
report.
can write.
Okay.
Even if you are not involved in that incident, you are just witnessing the incident. Okay. You can. Anybody can write.
Okay, when they wrote the incident report, then it will be escalate, right? So it will go to the root cause analysis and such. Who will do root cause analysis? My educational supervisor, or a clinical director, or who?
No, there is a risk management team in the hospital. They will go, they are all part of the quality department in the hospital. They will go through the incident report, and they are the one who will start investigation. And the investigation team will be already there. Mostly they are from somebody from the labor room, somebody from the ward, one person from the quality department, and your head of the department.
Okay.
And you yourself also, whoever raised the incident. You can raise it anonymous also. If you are, watching something that is happening, which is you feel you are not comfortable, not safe for the patient or the hospital, you can raise it as an anonymous person as well, or you can raise it with your name. So there is no issue in that.
Yeah, doctor, after root cause analysis, the team, they investigate, and what is the next step they will do?
Yeah, after the root cause analysis, they will find out what actually went wrong, right?
Yeah.
And if it is something deliberate mistake by the person involved, then it depends on where you are working, how your trust or the hospital, they take these incidents. So they might take an action against you, or if it is something which is done and not catastrophic, not ended up in some severe, like somebody's death. So same procedure as I told you, it will go into your e-portfolio, it will stay there, and you will do a reflective practice on that.
Yeah.
Actually, the risk management, they follow the fishbone model. Okay, they will try to identify multiple factors. The factors could be from the patient factors, hospital factors, staff factor. Okay, was there any lack of the the professional skills need, and then the risk manager, in the risk management team, they are going to have the couple of people involved in that particular scenario, or from the department as well. They are going to do the the complete the investigation, you can say. Okay, so they are going to involve the all stakeholders who were involved in that particular scenario, and then they are going to do the complete investigation, and then they are going to identify, so what were the the lacking, like Dr. Uzma said, that the training factor, it was lacking, that for example it was shoulder dystocia, and the candidate or the trainee didn't know how to do the shoulder dystocia, how to manage the shoulder dystocia. And then that's why the complication, the one of the complication of shoulder dystocia happened. Okay, so this is how it will go about. And they are going to identify that, okay, this was the potential likely the hood of this particular the complication. So then they will they give their recommendations. Then they are going to present that in the meeting. I'm sure you all know that every department has departmental meeting. Okay,
yeah.
So in that departmental meeting, so almost all stakeholders will be involved. Okay, your staff, your doctors, your consultants, okay, healthcare professionals, midwives, and the same result will be displayed on your the notice boards, and it will be the sent through the emails, it will be sent through the letters as well, so everybody will be aware of that. Okay, these are the recommendations, and this is how we have concluded that, okay, this was the reason for this the particular the problem. And now then the risk management and audit somewhat sometimes it the overlap, but basically it is not the audit. So the risk management is going to be the evaluation of the risk, finding the cause of the risk, and then working on that particular risk. Okay, so usually they follow the sub models and the most important models, and that is fishbone model. Okay, in fishbone model they are going to get all these the kind of factors they are going to evaluate. Okay.
Yeah, doctor.
Okay.
Yeah, electronic portfolio, it will go to my file, you mean?
Yes.
What is mean reflective practice? Reflective practice, who will do it, reflective practice?
You yourself. Reflective practice is reflecting back on your own practice. That what did you do? Okay. So do you think that, do you have any lack of knowledge? Do you think that you need any kind of, reflect is what, the peeking back,
Feedback.
or, the sneaking into your own, whatever you have done. All right. So reflective practice is that. Okay. Reflecting on your own practice in you can say the retrospective order. Of course, for example, I was involved in this case, and the shoulder dystocia happened, and somehow, the baby got the brachial plexus injury. Of course, brachial plexus injury is a very bad thing in shoulder dystocia. So I need to know that, what was the fault? Did I do, something? Do I need some kind of training? So reflective practice is, the other thing. And in reflective practice, they do have steps as well. Okay. So, what this particular incident has brought, the change into my life. Is this going to change into my practice? How I am going to improve on my shortcomings? How am I going to apply what I have learned through this, the particular station? Okay, the particular, you can say, the complication, and what I'll be doing in the future to avoid this particular risk. Okay, so this is called as reflective practice.
A fruitful session. First time I heard like that in
Oh, really? Oh, thank you so much. No. We will keep on doing. Me and Dr. Uzma, we have been discussing earlier as well. So we will be doing, the certain stations. So all you guys need is practice. Just come in the station and do try to. Because I always say knowledge is everywhere. This is up to you. What type of knowledge you really want to gain and how you want to utilize that knowledge. Okay.
Yes, doctor.
I really appreciate. Thank you. Thank you so much. Yes, Dr.
Okay, guys, so just quickly we'll go through this slide. I think we all have triggers in our hospitals, but this is from the RCOG, which is practiced in UK and Europe as well. So what are the triggers in maternity? It can be maternal incident, which can be maternal death, undiagnosed breech, shoulder dystocia, blood loss of more than 1.5 liter, return to theater, eclampsia, hysterectomy, laparotomy, anesthetic complication, ICU admission, venous thromboembolism, pulmonary embolism, third and fourth degree tear, unsuccessful forceps, vacuum, uterine rupture, readmission of mother. Then for the baby, it can be a stillbirth of more than 500 grams, neonatal death, low ABGAR score, birth trauma, a fetal laceration at cesarean section, low cot pH, baby having seizures, term baby admission to the neonatal unit, undiagnosed fetal anomaly, or a congenital anomaly in the baby, which is not identified in the antenatal period. Then there can be organizational incidents, which can be, sometimes you will come across a station that the records are missing. So that is also one incident, okay? So unavailability of the health record, delay in responding and call for assistance, unplanned home birth, faulty equipment, conflict over case management, potential service user complaints, medication error, retained swab or instrument, hospital acquired infection, or violation of a local protocol. Every hospital, most of the places, they have their own protocols, which are as per the international standards. So if somebody is not following that protocol, suppose there's a protocol of PPH in every hospital, or a protocol of shoulder dystocia, what you will do if you come across a certain situation. So you have to follow that protocol. If nobody's following, that is also incident. So as we said, that anybody can raise an incident. So if you see somebody, there is a protocol in place, but that protocol is not being followed, and you feel this is unsafe practice, although it is not done by you, but you can raise an incident, anonymously about the same thing. Okay. Okay, so 1 minute, please. All right. So there's a list of incident reporting in gynae as well. This is all from the RCOG. You can go through it later. And then steps in failure, mode and effect analysis. You examine a process in detail, outline every step. You identify what might go wrong and what can be the failure mode. To establish the consequences, each failure mode, effect of each failure mode. Identify, you find out the contributory factors. you see what are the controls, existing controls, are they enough, or you need to modify them? And then you use like prioritize the risk and decide which risk to accept and which ones to treat. As I said, that some risks are very small, so they can stay there, but there are some risks which are very, very they have very devastating effect on the patient and the hospital, so you need to treat that. So for them you have to devise an action plan. So these are the risk score metrics: low, slight, moderate, major, catastrophic. That's it from my side. Any questions, please? Okay, no questions.
No question. Everybody knows everything.
That is a question, once
That
there
is
is
a
no
question.
it is a big question. Either everything is a bouncer for you people or
Or
very
it was.
nicely, explained.
Thank you, Mera. That's very nice of you. Okay, great. So who is up for the next station with me? Anyone? Hmm? So this is going to be a communication skill scenario with integrated knowledge. Okay, so who wants to present? If no one, then we can conclude our session. If somebody wants to present or somebody wants to really, the gain anything out of it. So I think this is good for you, isn't it?
Come on, we have so many people.
Don't be shy, okay? We don't know you. Okay,
It doesn't matter. Even
it
if we
doesn't
know you,
matter
it doesn't
even.
matter. Come on. We have Hinza, Ibtihal, Humaira. Come on, girls. Mariam, Najwa. Rahatara. Who want to take the station? No one? Who is this Zoom user? You have a name, please? Oh, great. Humaira is coming forward.
Okay.
But I'm what? But she's saying something.
She's on duty actually. No, then it's better you don't come. Okay, you might get a call. So it's okay. It's okay. Okay. Anyway, so if nobody wants to, the present. So I had a very, the good station. So let me give you an overview that what exactly was that station. Yeah.
Ma'am, shall I, ma'am?
Who is this?
Monica, ma'am.
Okay, fine. Okay, fine. Okay. So basically, this station is going to be, in terms of communication skills. Okay. And keeping in view of the EBCOG curriculum, so it is going to be integrated with the integrated knowledge. All right. So you have 10 minutes to read and perform this station. Okay, complete.
Yes, ma'am.
Your time starts now. So remember, you have only 10 minutes, okay?
Yes, ma'am. Yes, ma'am. Shall I start, ma'am?
Oh, yeah, sure.
Hello.
Hi.
I am Monica, one of the doctors here. Am I talking to Mrs. Stacy Taylor?
Yes, doctor. I'm Stacy Taylor.
Your age?
Yeah, I'm 28 years.
How you want to be called?
Yes, Stacy is fine.
Stacy, you have come with the reduced movement of a baby. Am I right?
Yes, doctor.
And you have
Actually,
undergone
I was just having, the sometimes, since yesterday I was feeling that my baby is not moving properly. So, but since morning I was not feeling any movement at all. So I got very upset. So I came to the hospital and, I had a scan. I don't know what exactly it is.
Stacy, before discussing the report, shall I ask you a few questions to know more about you?
Yes, doctor, but I really want to know what exactly is in the ultrasound because I'm so worried.
Is there somebody with you? Are you alone?
No, I'm on my own.
Shall I call the specialist nurse to be with you for support? I'm afraid I do not have a good news for you, Stacy. I'm really sorry. Shall I ask her to be with you for support, Stacy?
Well, what kind of, the good, not good news? What does it mean to me?
I'll ask the specialist nurse to be with you so that she'll be as a support for you. I have verified the scan that has been done for you. Stacy, I am very sorry to be the bearer of the news. I have verified the report. It shows that the baby's heart has stopped. I'm really sorry, Stacy.
What do you mean by this? Her heart is stopped. You mean my baby has died?
Yeah, the baby has died, Stacy. I want to give you this bad news, but I'm really very sorry to be the bearer.
No, doctor, I'm sorry, are you sure that this is the confirmed news?
Yeah, the bedside ultrasound confirms absence of baby's heartbeat. Really sorry.
How is it possible, doctor? I was not hoping this at all. Since yesterday it was moving, but not that much. But can you please double check it? I mean, is it really, my baby is died?
Please take this tissue. Can you have this cup of water?
Yes, doctor. But why this has happened, doctor? This is so painful. I was not hoping for this at all.
I'm able to find you in a difficult situation, in distress. It will be a shock like news for you. I'm able to see you in a very difficult condition. That's why I asked the specialist nurse to be with you for support.
Okay,
It's really
doctor.
very
So
difficult to digest
what is
such
next
a.
now?
That's why I asked you to know the reason. For that only I have asked you. Shall I continue the consultation or shall you take, you
No,
want to take
doctor.
some more time? Shall I ask you a few questions?
Yes.
Did you have, so far, how was your pregnancy? Any complications you had, Stacy?
No, doctor, I was okay. Everything was okay. I had my all checks done, all reports, everything was normal.
Is this
But
your, no, please tell me, continue, please.
yes, this is my first baby. So, oh my God. My God.
Is it a planned pregnancy or any IVF like that you have done?
No, I mean, I conceived on my own spontaneously.
Did you have any high blood pressure or any medical condition for which you treated the GP?
No, doctor, I have always been given, the positive report about everything that, I'm okay. I'm not, that doing anything. My reports are okay. Everything is okay.
Are you aware of your blood group?
Yes, it is O positive.
It is really a difficult condition. In 1 in 200, this happens. This sort of baby dying in womb happens. And in 50, in
so
1
it is
in
normal. Is it
no,
normal, doctor?
No, in 1 in 200 it happens. It is not so common, but it has been found that it happens like that. And in 1 in 2 of the babies dying in such a condition, the cause is not found. But in 1 in 2, we are able to find the cause.
So, doctor, what is next? What will happen now?
It will be, you will be under the care of the consultant, lead unit under care of my consultant and the specialist nurse, the pain doctor, the physician, and the psychological counselors and the support groups and bereavement team is there. So my consultant will come now and she will be debriefing you everything. I also apologize to you for the same. This has happened. Whatever may be the reason. So if you want to have some women want to deliver the baby as early as possible. Some want to leave it in the hands of nature. Whatever decision you make, the treatment will be given according to that. If you want to have the delivery of the baby as early as possible, you'll be given, the consultant will be offering you the medication for that. A gel will be kept inside your vagina. After you'll be in admission in the labor ward in a room which is away from the other patients, so that you will not be disturbed by the sounds, and you'll be with your partner and you'll be given fluid in drip, and you'll be given one-to-one care, and continuous support will be provided to you. And with that medication, the neck of the womb will open and you'll be given adequate pain relief, and grouping and saving also will be done for you, and the progress of labor will be monitored then and there by the specialist midwife, and the consultant will also come and take care of you frequently if necessary. And then you will have a painless delivery, do not worry, and you'll be given utmost care, and you'll be treated more than a normal delivery. Your care will be there. You'll be treated with so much of care, and the delivery, after delivery, you'll be given, sorry ma'am, you'll be given active management of the 3rd stage of labor, that is giving injection to reduce your bleeding also. And if you want to have the to test to find the cause, you'll be offered some blood tests. And if you want, the baby can be tested in 3 ways. That is, the after birth will be sent for test, and some swabs also will be taken from the after birth. Some swabs will be taken from your vagina also, and blood culture may be taken from you, and blood for it. Some tests like blood sugar, HbA1c, and some viral markers, that is infections like torch infection, that is cytomegalovirus, and these tests will be done for you. And if you want to have the testing for the baby, a minimal testing can be done, or with the small cuts made on the baby, with the baby will be treated with dignity, through the small cuts. Some tissue will be taken for test.
Monica, I would like to stop here. Because this is not about postmortem, okay?
Okay, ma'am. Sorry, ma'am.
All you need to do is that you have to break the news first, and then just give her, because you are going to be performing in 8 to 9 minutes hardly, okay?
Okay,
so
ma'am.
remember
Okay,
that
sorry.
in this EBCOG, you don't have to go for so
I do
many
not know,
things.
ma'am. Okay, ma'am.
Exactly. So you will just break the news, and you are just going to give her the time this particular task is going to, the confirm regarding that how you behave, how you give the news, how you are going to talk to the woman. All right. So, always remember, even in the MRCOG or MRCPI. Okay. Hi, Mustafa. How are you? Good to see you. Thank you so much.
The time management is very bad in me, ma'am.
Hello, and thank
Time
you.
management. Hi, how are you doing?
Alhamdulillah, everything okay. Sorry, I came late because I was in hospital.
Oh, okay. No problem. You can listen to it afterwards, and of course, you can perform any station if you wish to. Okay.
Okay, thank you so much. Okay.
Welcome. So regarding to this scenario, so Manikam, what you have to do is, and all of you guys, okay, don't just try to read the question to the patient. Okay, this is really irritating. Okay, this is really irritating at times that you are just reading the question first and then you are coming to the point, because in this particular scenario she is very anxious. Okay,
The
she
time
had
is lost. Okay, ma'am.
she had less fetal movements since yesterday, since morning, no fetal movements. And the one registrar confirmed IUFT. You have also confirmed IUFT, and now you have to give the news. So generally speaking, you are going to start. So is this Mrs. Stacy Taylor? Yes, doctor. So how would you like to be addressed? Stacy is fine, doctor. So Stacy, can I confirm your age, please? Yes, I'm 28. Okay. So Stacy, I understand that you had a scan done and now you want to know about the report and everything. Am I right? Yes, doctor. Do you have any particular concern to discuss? Yes, doctor. I really want to know that what exactly that blah 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 blah. Yes, I understand, and this is quite understandable that you are anxious. So, Stacy, tell me that are you on your own today, or is somebody accompanying you? No, doctor, I'm alone. All right. Because Stacy, I have the some I mean so many things to discuss with you, and I have one difficult news to tell you. What kind of difficult news? Hmm? Stacy, the we have, and the because that might be upsetting for you as well. And then I have to talk to you for the couple of things. So would you like to call somebody in, or shall I call my nurse to sit with you and give you support? Oh, what do you mean by the difficult news and the bad news, doctor? Stacy, we have done a scan on you. My registrar has done a scan on you, and I have reconfirmed that that your baby was not moving inside the womb, and the baby's heart also got stopped at that time. It means that baby has died in the womb. What do you mean by doctor died? What do you mean? No, it cannot happen. Blah blah blah. She will start crying. Okay, give her time. No problem. Okay, give her time. Give her time to react. Everybody will react to such news. All right. So then you are going to the show your sympathy. I understand, Stacy, that this news has come to you as a shock. And are you okay? Are you okay to talk to? Okay. Or shall I schedule another appointment? No, doctor, because this is exam. And she also knows that she will come back in her senses, the right away. And she will ask you that, what next? So you will quickly, come to that. Don't unnecessarily drag that, I'm so sorry. I'm so sorry. I mean, okay. Yes, we are sorry. But it doesn't necessarily mean that you are, the dragging this thing. Okay. So Stacy, would you like to would you want me to discuss the further management, how we are going to discuss? Yes, doctor, because I'm really upset. Yes, I understand. So Stacy, the since you said that you have been okay throughout the pregnancy and everything was okay, and just let me tell you that in half of the cases we might not found that we might not find any kind of cause as well. Okay. And so I mean sometimes it happens in all these cases, but yes, we have to take things further from here. So what we need to do is that that I'm going to explain you that what are the choices of birth for you. Okay. So the more than half of the women, up to the 80 out of 100 women, they can deliver themselves on their own within like 24 to 48 hours. Okay. And many women who do not want to take any stress, so we can kickstart the labor as well. We call it as induction of labor. And the hardly so these are the options. Okay. So what happens is that that baby is going to be delivered, and then the later on we might have some kind of test to evaluate the cause of the death as well. So certain tests can be performed on you, certain tests can be performed on baby as well. All right. Okay, so doctor, why this has happened? Yes, like I said, that in half of the cases, we might not find out the cause, but in some cases there can be, the certain, the causes as well, like, the if you had any, the high blood pressure, high blood sugar, or any other problem, like in baby, if there is, the unidentified anomaly, unidentified, the genetic problem. So sometimes, there can be multiple problems. So that's why, the after the birth of the, the baby, then we are going to be able to find out the cause. All right. Am I clear so far? Okay. So do you want me to repeat anything? No, because in this particular exam they don't want you to talk about each and everything. Okay, they are just going to judge on your communication, that how you are going to behave. All right. So
Yes, ma'am.
you are going to give, the warning note, what we call it as the warning shots as well. So the first of all, you can see that, if you are scanning at the same time, then you can see that I'm unable to see any movement of the baby on the scan. First warning shot. And I am also unable to see the baby's heartbeat as well. Second warning shot. Oh my God, do you mean that my baby is dead? I'm really sorry to give you this news. Yes, the baby has died in the womb. Okay. So after giving the bad news, don't unnecessarily go here and there. Okay.
Yes, ma'am.
Because,
Yes, ma'am.
this type of the bad news, it will definitely, they give impact on the, the woman as well.
Okay.
So what will happen is that be ready to find out how much has been absorbed by the patient and what would be usefully repeated by you. You have to tell a little, pause, then observe the reaction and tell a little bit more and repeat if necessary. Or you may want to give, the later on the written information, and
Yes, ma'am.
must always leave the patient with them and, the avenue to get support from you, from your team, from any emergency telephone line as well. Usually in this type of, the scenario, because this is exam, so of course, they are not going to ask you to tell so many things. Okay. So, there are some, the examples of phrases what you can use. Okay. So almost all exam, because literally, they are, and luckily they are in English language, isn't it? So,
Yes, ma'am.
the theme is going to be same, that you have to speak to the patient. All right. So you can simply, these five are, the particular example. I'm sorry, what I'm about to tell you is not good news. I'm so sorry. I have some bad news to tell you about your baby. Then you can say, I have been asked to come and explain the ultrasound findings, and I'm afraid to say that what I'll be telling you is not that good. Unfortunately, I have a bad news about your baby. Okay. Then this can happen. The ultrasound scan you have just had, unfortunately, has picked up major problem or any major problem with the baby as well. If it is about the congenital anomalies, I'm afraid this is not even good news as well. Okay. So any phrase you can pick, anything you can, say, the main focus is going to be your tone, your pace, your expressions, how you are going to deliver, how you are going to show the sympathy, empathy. Okay. So breaking bad news, basically, sometimes there are top, the do's and don'ts of the breaking bad news. Do is what? Have the facts to hand. You should know that what you are talking. Check if the patient wants anyone else present. Clarify what the patient knows or suspects. Be prepared to follow the patient's agenda. Observe and acknowledge the patient's emotional reaction. Check patient's understanding of what you are saying. But don't give too much information at one time. Okay. Like in this Manikam, you don't have to give, and even in, the other exams as well, you don't have to go for postmortem that your baby will be given cuts and, the dignity and respect. No. Don't alarm any patient.
Okay.
This lady is going to be so vulnerable, so she might not speak to you a single word after it. Okay. If you will, the bombard her with a lot of information, so, she might not, be able to talk to you. Don't give inappropriate reassurance. Okay. Then in this particular, for example, if she's again and again, insisting, no, I want your, the consultant to, just reconfirm. Okay. So you can simply say in that, and this happens not only in this scenario. For example, in endometrial biopsy, where you have seen the complex hypoplasia, okay, the atypical hypoplasia. For example, this is, the the any biopsy, on biopsy you have seen, the cancer of anything, and she is insisting No, I want another confirmation. So in that scenario, you can, bring the sentence, okay, as you are insisting that much, so, I can talk to my consultant and I can arrange another scan. But let me tell you, this is not going to change the outcome. Okay, because we know that this is not going to change the outcome. The outcome is going to remain same.
Same.
But
Yes,
of course, at the same time, you can't give unnecessarily psychological stress to the patient that, okay, we are not respecting your wish. We are just giving you a lot of information. We don't want you to speak. We just want to, show what we know from our curriculum. Okay.
Okay.
So
Okay.
remember that we don't have to give any inappropriate information, any inappropriate reassurance, answer questions unless you have the facts in hand. Hurry the consultation, use euphemisms, okay? Stop emotional expressions from the patient. Agree to the relative request to withhold information from the patient. For example, if it is, the mother, for example, if it is husband, sister, and even daughter. If she's asking you that, please don't tell it to my, mother. Please don't tell it to my, the husband. Please don't. No, we have to. You can simply say that, look, I understand that this is such a difficult news, but I believe that you might be needing, some kind of support. So it's better to involve, it's better that we tell this news to your husband that, you are having this problem. You have this problem. Your baby has died in the womb and blah, blah, blah. Okay. So, this is how, you have to do, but don't, again, your pace should be very, the constant. Don't hurry the consultation. Okay. Don't just try to give her information, blah, 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 A, B, C, D, E, F, G, and then khalas. No. Okay. This needs, a lot of, the patience and practice as well. Okay. That's why I have emphasized earlier that the practice is a key for any OSCE there is. Everybody is full of knowledge, but how to bring that knowledge to the world, in front of the world, that is the art. Okay. So that's why it is termed as, the OSCE. Okay.
Nice. Thank
Clear
you so
now?
much, ma'am. Thank you for the opportunity and your advice, ma'am. Thank you so much.
Okay. Clear, everyone? Looks very easy because everyone thinks that IUFT, we do BBN of IUFT in almost all exams, isn't it? So we always expect that, okay, I can do it, but trust me, this is very important that if you are not rehearsing, if you are not practicing, so this is really going to be the somewhat challenging in your real exam as well. Doesn't matter if it is EBCOG or MRCPI or MRCOG. Okay, clear, everyone?
Dr. Zaib, I have a question, please, general about intrauterine fetal death. So shall we do all investigations at the time of the intrauterine fetal death involving fetal-maternal hemorrhage, even if she's not Rh negative?
Well, atypical antibodies can happen. Okay, according to the guideline, FMH is the the recommended investigation. Okay.
Okay. Other investigation according to the risk factor, shall we do it, or shall we postpone it after delivery?
Postpone it. Not in when you are giving any the news. So don't talk much about the so many things. Rather, if this station is about that how you have to explain about the postmortem, then of course you can go about the postmortem, and then you can talk about the reasons of and the types of postmortem as well.
Yeah, doctor, I understand structural discussion. I mean, in structural discussion, not in this case.
Well, in this EBCOG, if you particularly want to talk about, so they don't really bring this, as a structured discussion. Structured discussion is going to be on risk management, on critical appraisal, or it is going to be involved in one of the, the handover case, and plus it will going to be involved in the complex technical skills. Okay, so don't worry about it.
Yeah. Okay.
See here in this station, they are actually testing only how you will break the news to the patient. Okay, so this is most of the focus is on breaking the news. This patient cried for about 1 minute, and you have to stay quietly, let her cry, no problem. And whenever the candidate is trying to start with the this one postmortem, they said they don't want to listen about postmortem. So the station was not about giving the postmortem details. It will be this one, that one. The station is just to break the news and then give her the initial management, what you will do, which will include if you want to do certain investigation right now, what will be her plan of management and mode of delivery, and give her the patient information leaflet and arrange another appointment, because you will not do it right there and then. If the patient wants, yes, okay, but most of the time patient will say, I will go home, I will discuss with my husband or partner or whatever. Okay.
Exactly.
Can we say about this delayed delivery by the management by
You said
monitoring the
we will.
coagulation profile? Yes,
No,
ma'am.
no. You said that we will leave the hands in hands of the nature,
Yes,
if I'm
ma'am.
not wrong. Okay. So you can
Hmm.
simply say that we will we have got a couple of the options for your delivery. One option is letting the nature its course.
Yes,
Okay.
ma'am.
Don't say that hands in the hands of the nature. I mean,
Okay, ma'am.
rather you can use the simply that the one of the option is that let nature takes the course. Okay, we call it
Yes.
as expectant management. And with this management, almost there's 80 out of 100 women can deliver within 24 to 48 hours. So if you wish to delay the delivery, after that we might need to offer you some tests as well. So
Yes,
simple.
ma'am.
Okay, don't just go into the detail that we have to check for the coagulation, blah blah blah, because it will
Okay.
unnecessarily take your time.
Okay, ma'am. Thank you, ma'am.
Okay, great. Okay, so clear everyone. Okay, any question or no question?
Felt as if I'm really talking to a real mother weeping.
Oh,
Excellent,
really?
ma'am. Excellent, ma'am.
I know I'm going to get a Best Actress award after my all these exams. Even the other day, I think who was telling me, in my the last Friday, I think Ibtihal, no, not Ibtihal, some other candidate. It was also, the kind of on male factor female factor infertility, and of course, yes, the things are there. So yeah. Of course, this is our job, so we have to bring the role player as well. We have to cry, we have to laugh, we have to, be angry. So
I can never forget, ma'am. This.
Okay, that's very good. Thank you so much. Okay, thank you so much, Ibtihal. Thank you so much, everyone. And we are open for the registration for mocks and the course as well. So anybody who wants to take the focused mentoring from either of us or either both of us, so we are always there. Okay. Apart from this EBCOG, we are open for MRCOG and MRCPI registrations as well. Okay, you guys can reach out to us, individually or from our team as well. So our team is there, med exam expert team. Okay, so our representatives are there, so you guys can reach out to us. All right, we will be happy to coach you, and please do make us your the what you can say the partner in your success as well. We would love to do that. All right. So thank you so much. Thank you so much, Zoom user, whoever are you. But thank you. Okay. I can see Rahat is here. Hello, Assalamu alaikum, Rahat. I hope you are okay and you are doing well. This is so lovely to see you after so long.
I'm fine, thank you.
Okay, I was hoping to hear from you. I really miss your voice at times. Yes. Inshallah. Okay, everything will be good. So I'm here, Rahat, if you need any kind of help or support. Okay. Yes.
Okay, thank you so much.
Okay, my dear. Okay.
All
Thank
right,
you so
thank
much.
you, everyone. Thank you so much, Zaib and the Med Exam
Thank you
team
so much,
for
Dr.
arranging
Uzma.
this session.
Yes.
Thank you,
And
ma'am.
thank you all for coming and participating. We will be conducting more sessions, and please do reach out to us whenever, whatever information you need, we are available. Okay. Thank you very much.
Thank you so much, everyone. Bye-bye and good luck.
Thank you, ma'am.